Yeah, Emily, thanks for the introduction. Rather lengthy, but what you really need to know about me, I think, is that I'm a physician who for quite a long time now, almost 15 years, has been primarily treating tobacco use disorder in so-called vulnerable populations, but really by what we mean by that is people with mental illness and or other substance use disorders. And we don't work with that population specifically by design here, but we are in a low smoking prevalence environment here in British Columbia in Canada. In fact, in the city of Vancouver, our smoking prevalence rates are probably as low as 5%. And what that means is that those left behind are invariably those with mental illness or substance use disorders. So we don't limit our treatment to that population, but that's the population that we're almost exclusively involved with. I'm going to speak maybe only for half an hour because I'm hoping to leave a good 15 or 20 minutes for conversation. I think that's a more valuable use of time. I suspect a lot of what I present is not going to be new. I hope it's not too much like review, but by leaving adequate time to get into some of the nitty-gritty of this stuff, we may have more fun. So first of all, my land acknowledgement. I'm at home in Vancouver, which of course is on the traditional territories of the Coast Salish people, the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And before I go any further, of course, my disclosure slide. So I have no relationships with any for-profit industry. You can see the list of health authorities and governmental agencies there listed. At the bottom of the slide, you see highlighted no tobacco, vaping, or alcohol industry funding. And I added that recently because I thought it was kind of evident that that's the case, that I'm not on the payroll of Philip Morris, or I'm not on the payroll of one of the vaping producers, who are much one and the same thing, of course, these days. The reason I added it is that increasingly, with the growth of the concept of tobacco harm reduction, which is from my perspective, an entirely legitimate concept. But there's increasingly people within the medical community who do receive funding from vaping industry, who do speak enthusiastically about tobacco harm reduction. And I have no issue with the right of people to express opinions, but I think it should certainly be disclosed that if your money is indirectly coming from Philip Morris, or you're being paid by Philip Morris, and you are speaking in favor of so-called less harmful nicotine products, then your source of funding should be on that page. And sometimes it's not. But anyway, for clarity, I have no such funding. Okay, so this is roughly what I plan to speak about. As I said, the groups that are disproportionately affected by tobacco that I will speak about mainly are those with mental illness and substance use disorders. But of course, there are other groups that we can just acknowledge today. I'll also talk about the rationale for treating this group and maybe think about why we don't do it optimally, and what some of the systemic barriers are. And then number three, talk a little bit about some of the actual clinical approaches, some of the things that actually happen in the clinic when we're presented with these hard to treat populations, people with comorbid schizophrenia or with alcohol use disorder, who are showing up asking for help, and what kinds of things do we do in the clinical setting. So that's roughly what I will run over. But as I said, try and leave lots of time for questions. This is not news. I'm sure everyone in the room is familiar with how we define tobacco use disorder. This is from the DSM-5, which of course is the American Psychiatric Association's diagnostic manual. And we define tobacco use disorder in the way that we define any other substance use disorder. And you can see the list of criteria there that we go through and tick. And the more that you are positive for, the more severe your disorder is considered to be. And the diagnosis of substance use disorders is split up into these four categories, really. One that refers to control over the use of the product. Two, that refers to the social instability created by the use of that product, which doesn't apply that well to tobacco, of course. Number three, criteria that refer to harm from the use of the product. And number four, criteria that refer to the physical dependence on that product. So that's how we define tobacco use disorder. But what we're really talking about at a biological level, at a neurobiological level, is a change in the midbrain. And if you think about the young tobacco user in my clinical setting, most of those that I see will say that they initiate at the age of 11 or 12 years of age. What those individuals are doing when they first experiment with tobacco is that they are landing nicotine very quickly in the brain, 7 to 10 seconds when delivered by cigarette smoke. And nicotine lands in that receptor, the alpha-4 beta-2 nicotinic acetylcholine receptor in the ventral tegmental area. And that leads to a little squirt of dopamine and probably other neurotransmitters in the nucleus accumbens. And that is experienced as pleasure and a whole bunch of other subtle physical experiences. After the initial use of nicotine, that becomes a reinforcing or a pleasurable experience that is repeated. And what happens, particularly in the young brain, after a few weeks or a few months of use, is that when use is stopped, or when this individual decides that this is no longer cool or interesting and decides to stop, the upregulation of these receptors that has occurred leads to the emergence of a very predictable withdrawal syndrome when that delivery of nicotine is interrupted. And that withdrawal syndrome, again, you're all familiar with: the irritability, the mood changes, and particularly the craving, which drives continued use. So we know that there are brain changes in the midbrain of tobacco users. And that receptor, that alpha-4 beta-2 nicotinic acetylcholine receptor, is where we focus most of our pharmacological efforts with the use of nicotine replacement therapy and varenicline in particular, which I'll speak about in a few moments. So let's talk about prevalence rates. Just a little plug for Canada. We're doing rather well. Our prevalence rates, maybe can't see the end of this graph, but we've gone from close to 50% prevalence rate in the mid-60s right down to around 10% today. And of course, that's occurred because of all these very good things that we've done in public health with warning labels and smoke-free public places and taxation and all these great interventions that have led us to these very good declines. You in the United States have done very similarly. I pulled up this data yesterday from the American Lung Association. Smoking prevalence rates down to around 12%, I believe, in the United States now. Again, from those kinds of highs in the 40 to 50% kind of range in the mid-60s. But these prevalence rates don't tell the whole story, of course, and that's really what we're talking about today, that there are subpopulations where prevalence rates are in fact much higher than these headline rates. And I wasn't familiar with the prevalence rate in Kentucky until yesterday evening, but I looked it up, and I believe your prevalence rate is twice the national average, in the low 20s. But what about people with mental illness and substance use disorders? So this graph kind of highlights the point that this is a disproportionately affected subpopulation. This is a graph that looks at the years from 2009 to 2014 across the horizontal axis. And if you look at the blue line, you see that smoking prevalence rates in that period, around 15% in 2009, dropping a little bit to around 13% by 2014. But then the red line highlighting the prevalence rates in those with a past year serious mental illness, and a dramatic increase now, at least a doubling of the rates, around 30% in 2009, with a little bit of a drop by 2014, but still well over 25%. So smoking prevalence rates have at least double the general population. If we break that down a little bit by diagnosis, this is 2007, so general population smoking prevalence rate still above 20% at that point. but then compare with all of these diagnostic categories. People with ADHD, for example, smoking prevalence rates of over 35%. People with bipolar disorder, smoking prevalence rates of 45% or more. And of course, people with chronic schizophrenia, smoking prevalence rates in this survey of approaching 60%. And we've seen smoking prevalence rates of 70, 80, even 90% in some research that's looked at prevalence rates amongst people with chronic schizophrenia. A very interesting conversation, one that I won't spend much time on today, is why. Why do we see smoking prevalence rates in people with schizophrenia of 60% or higher? And there are a number of hypotheses. And whenever there's a number of hypotheses, what that tells you, of course, is that we don't really fully understand what's going on. But there's some evidence that some elements of schizophrenia, some of the symptoms of schizophrenia are actually alleviated by the use of tobacco-delivered nicotine, to the point that there has actually been research in the idea of using nicotine as a treatment for schizophrenia, though that's never really come to fruition. And as far as I know, there's no studies in humans that have been able to demonstrate a beneficial effect in people with schizophrenia. Nicotine, of course, improves cognitive functioning. We know that cigarette smoke contains compounds, not nicotine, contains compounds that can enhance the metabolism of many of the drugs that are used in this population. And so we can reduce medication side effects and again, make the use of tobacco-delivered the use of cigarettes something that makes these patients feel better. So there's the self-medication hypothesis. There's, of course, the shared genetic vulnerability hypothesis, the idea that there is a genetic makeup that makes one vulnerable to both disorders, to schizophrenia and to tobacco use disorder. And last but not least, of course, and I'm sure everybody in this room will be familiar with some of the elements of the culture that certainly was more predominant 30 or 40 years ago, but still remains to this day, where tobacco use is normalized. And even though in our province, it is technically against the law to deliver cigarettes from a healthcare facility, I still hear from time to time of cigarettes being delivered from the nursing station for some of these patients, which is at one level understandable. Culture is hard to change, but really, I think, quite sad that we're still looking at these kinds of practices in 2024. There are other populations. This is a Canadian slide, but I think the principles apply. We see much higher prevalence rates in people who don't complete high school compared to those who graduate from university by a factor of 4. We see much higher prevalence rates in unskilled workers compared to those who work in the professions by a factor of 2.6. And then at the dark blue box at the bottom just demonstrates that we have much higher prevalence rates in our First Nations populations here in Canada. Which gives me an excuse to show you this slide. I took this photograph myself in the northern part of Nunavut, where I was assisting their government with some of their tobacco control initiatives. And though it's a very beautiful place, the point that I want to make when showing you this slide is their smoking prevalence rate is 60% amongst adults in Nunavut, and their prevalence rate among pregnant women is 60 to 80% in the Baffin region. So we can feel good about these headline prevalence rates coming down to almost single digits. We can talk about tobacco endgames and the legislative levers that we now need to think about pulling to get down to these really ambitious targets in Canada. Our federal goal is less than 5 by 35, so less than 5% by 2035. But we have outliers where there is a great deal of work still to do. So getting back to those with mental illness and substance use disorders, it's worth thinking about why we've left this population behind. And I heard somebody say some years ago that tobacco denormalization was an entirely laudable goal to stigmatize tobacco use such that the prevalence rate would fall, and that concept has been quite successful. But what we've inadvertently done is we've stigmatized and further marginalized tobacco users. We've denormalized tobacco users. And that stigma has not been helpful in these populations presenting for treatment and for us, in fact, treating them. We have effective treatments, but we don't really have systems that deliver those treatments. I work in an outpatient setting where we offer longitudinal care. We see people for as many times as they need to be seen, whether that takes weeks or months or years. But these kinds of outpatient dedicated tobacco treatment settings are few and far between in Canada. We also have a lack of coverage for medication. So you're going to hear me talk a little bit about individualizing treatment in a few moments and using more aggressive treatments for these more highly dependent patients. But by and large, we don't cover the cost of those kinds of approaches. We have very few integrated programs in mental health care settings. We have a higher prevalence of staff who smoke in these settings. So we clearly have lots of obstacles to delivering best practice treatment, and we still have a paucity of research into the efficacy of these interventions. So what's the rationale for treating these populations? Well, as I've already pointed out, we have high prevalence rates, of course, but really crucially, and the thing that we need to have policymakers understand is that these populations die 15 to 25 years earlier than the general population, and most of that is due to the use of tobacco. It seems staggering that we stand by and watch this play out without making this a real national emergency. And some of the arguments that have been used to not enthusiastically provide tobacco treatment for these populations. These patients don't want to quit. These patients are not able to quit. There are more important things for these populations to worry about. Are just increasingly demonstrated to not be true. We have many surveys that show that these populations are interested in cessation. We know that they're able to quit if we treat them intensively enough. And in terms of more important things to think about, well, dying 25 years before the general population seems to me to be a pretty strong motive to get treatment to these folks. And now the evidence is really accumulating that in the mental health population, actually treating tobacco improves outcomes. I'll show you this systematic review by Gemma Taylor and colleagues from the BMJ. Many of you are familiar with it. And we even have some evidence that for those in substance use treatment settings, offering smoking cessation interventions actually improves outcomes from the so-called primary substance use. Here are some of just a little smattering of evidence. Patients in methadone maintenance treatment, 80% would describe themselves as somewhat interested in quitting. In an outpatient program for people with alcohol use disorder, more than 3/4 willing to consider stopping smoking. In an inpatient substance use setting, 77% were certain that they wanted to quit smoking. And there's multiple surveys in people with schizophrenia suggesting that these populations are interested in quitting smoking. Now, whether these populations believe that they can quit smoking with conventional treatment approaches is another matter. They often demonstrate low confidence in cessation, but that's different to saying, yes, I would like to be free of the ball and chain of tobacco addiction, which most of these patients, when asked that question specifically, will say, yes, I am interested in that. This is the Gemma Taylor publication. Please go and find it if you haven't seen it. But this was a very interesting systematic review, and actually took a large number of studies that were smoking cessation intervention studies, and compared those who quit compared with those who didn't quit. And what they found was that those who quit had reduced depression, anxiety, and stress scores, and improved mood and quality of life scores. And that applied in those with pre-existing mood disorder as well as general population. and the effect size was estimated to be similar to that of SSRIs. So when you kind of think about that from a clinical perspective, the way I read that is if I have somebody walk through the door, or if a family physician has somebody walk through the door who has a mood disorder and is using tobacco, just doing smoking cessation would be similarly effective to putting that individual on an SSRI. Now, I'm not suggesting we do that. Of course, we do both ideally. But it underscores the point that there is this growing body of evidence that people with mental illness actually feel better when they quit smoking, contrary to these long-held myths to the contrary. What do guidelines say? Well, this is the Canadian guideline from Peter Selby and colleagues at CAMH. You see their summary statements there. Healthcare providers should screen persons with mental illness and addictions for tobacco use. Summary statement number 2, healthcare providers should offer counseling and pharmacotherapy, the two efficacious treatment modalities for tobacco use disorder, to persons who smoke and have a mental illness and or addiction to other substances. And summary statement number 3 is an important caveat. While reducing smoking or abstaining, healthcare providers should monitor psychiatric conditions, monitor medication dosages. And this is another piece of this puzzle, that when we treat these populations, we do need to have the skills and the clinical programs to monitor for a worsening of symptoms and even those with substance use disorder to monitor for relapse, the kinds of things that can occur when we treat tobacco use disorder. This is your guideline from 2008, a little old now. You see highlighted there from the summary statements: support every patient identified as willing to quit with counseling and medications. Tobacco dependence treatments work across a broad range of populations. So guidelines across the world are making it clear that we need to treat these populations. But despite that, as I've already said, there has been historically a limited effort to treat this population. I think there are a number of obstacles, but it begins right from not asking the question, not screening, not documenting tobacco use status. This may be because people who work in these settings are rarely trained in the treatment of tobacco use disorder. Undergraduate training is often inadequate. I know I went to medical school 100 years ago, but I remember having one lecture on tobacco, I think, which seems incredible in a 5-year program. And most healthcare professionals have not been to these postgraduate training programs that occur at the Mayo or at Teach in Toronto. And if we can start to turn this ship around and see this as a co-occurring disorder, as a DSM-5 diagnosis that goes on the problem list, we might then be more inclined to integrate treatment into our existing mental health programs or our existing substance use treatment programs. So this is the bit that I actually like to talk about clinical approaches. So this is a patient that we saw some years ago, and I'll give you a little taste of how he presented. 53-year-old male, single, lived in shared accommodation, COPD, long history of chronic schizophrenia, which was stable. Childhood trauma. His father had an alcohol use disorder. He was physically abused as a small child. Initiated at age 11, 2 packs of cigarettes a day. Time to first cigarette, 5 minutes. Of course, that's the basis for the Fagerstrom test. So highly dependent, very little historical quit time, apart from a little bit of time in hospital on NRT. He had attempted to quit and had done so by switching to vaping. But this had not really been successful in helping his tobacco use, and he'd really become a dual user. Had tried NRT at standard dose, had tried bupropion for a maximum of 3 weeks with very little success. Also drinks 5 cups of coffee a day, daily marijuana, very common, certainly here in British Columbia. Comorbid marijuana use is almost the norm. 2 standard units of wine per day. And though he presented at the clinic, you see his medications there, his onclozapine. Though he presented at the clinic, having been referred by his mental health team, he told us that it was in fact too hard for him to quit. Nothing had worked. He had no confidence in his ability to change. And at this time, he wasn't really prepared to try. And I present this case because, one, because it's not that unusual for us to see patients like this. But I think it's much more interesting than presenting a case of somebody who comes in and tells that they want to quit, they've had an MI, they're ready, they're motivated, we put them on varenicline, they stop. Those stories are not very interesting. Those are nice and they're easy and they're fun to have those kinds of experiences. But these are really much more interesting and much more clinically challenging. And so we all recognize this type of patient, I think, clearly a patient who is ambivalent. And one of the messages that I think we need to get out to our wider community is that for these kinds of patients, the clinical response should not be, well, go away and come back when you're ready to make change, but that we have a treatment for ambivalence, and the treatment is motivational interviewing. And you're all familiar with MI and some of the foundational elements of MI. We would try and develop rapport. We would express empathy. We would develop discrepancy. We would try not to engender resistance. We would support their self-efficacy. In a nutshell, we would do all the things that we could do to try and make sure that this patient comes back for a second visit and a third visit. So engagement is what this is all about for a patient like this. And the way that this story played out was that this patient did begin to do some tracking, was agreeable to wearing a nicotine patch in a so-called reduce to quit paradigm. I'll talk a bit more about that in a few moments. So the only goal for this patient was put a patch on, see if it helps you to reduce. And in fact, this patient did quit smoking, did subsequently relapse. Again, that's not unusual, but was able to have some success despite initially presenting as highly ambivalent. So medications, apologies for this rather busy slide. We have three main classes that we use in treatment, from left to right: varenicline, also known as Chantix in the United States, Champix in Canada. We have bupropion, also known as Zyban, and of course we have NRT. We have long-acting NRT, which is the patch, and we have a number of short-acting preparations. We have gum, lozenge, and inhaler here. I believe you have a nasal spray in the United States, which we do not have. And you can see in the bottom right of the slide the dosing schedule, and you'll see doses there that are higher than the standard doses. And I won't get deeply into this just now, but it's not unusual for us to go off-label, to have people on two patches or two patches and gum, titrating to effect. This is not dangerous. This comes with very little risk. Of course, nicotine toxicity can occur if you overdose a patient, but nicotine toxicity is not life-threatening. And the reason we do this is that historically we have underdosed these patients. And if you are a 2-pack-a-day smoker with chronic schizophrenia and we put one patch on you, invariably that patch won't touch the sides. But if we are able to titrate carefully up to 2 patches or more sometimes, then we do start to see some beneficial effects of these approaches. So aggressive use of NRT is certainly one of the things that we do in our clinical setting, and we do other kinds of combinations as well with some of the oral products. This is research from general population. And what we see there is that in our really very well-established body of research now, when we use combination NRT, we triple the likelihood of cessation at 6 months compared to using placebo. Similarly for varenicline, and bupropion and single agent NRT are about twice as effective as placebo in trials. So the top two are our usual go-to. We certainly like to use combination NRT. We certainly like to use varenicline. But again, one of the obstacles that we have is that we have good coverage for NRT in this province, but our province will cover 12 weeks of single agent NRT. So if you want to use patch plus gum, how are you going to fund that? always a challenge. We have bits and pieces of supply. We're able to give people free gum sometimes, but certainly one of the challenges is cost. And I think if we're going to have success with these hard to treat populations, we have to find a way to get over this cost obstacle. We don't have enough evidence into more aggressive approaches. This is something that we do from time to time. We have small studies to support the effectiveness of patch plus varenicline. This is a South African multi-center study, only 400 and some patients, but 12 weeks of treatment. And the results suggested that we have an odds ratio for cessation during the last 3 weeks of treatment of 1.85 for varenicline and patch versus varenicline alone, with no significant difference in adverse events. And so these are the kinds of things that we are increasingly doing in these dedicated cessation settings. But again, cost commonly an obstacle. I'm sure everybody is familiar with Eagles. Eagles was the large, very large, in fact, the largest ever smoking cessation trial that was created in response to the initial noise around varenicline causing a worsening in mood and potentially causing suicidality. The FDA and Health Canada and the European Medications Agency put their heads together and asked the manufacturers to do this trial to try and tease out whether in fact this was a real risk, and if it was, what was the magnitude of this risk, what was the degree of this risk. And so this large global study was created, and I think you all know the headline outcome. It was intended to be a safety trial. The main headline outcome was that when you compare NRT versus varenicline versus bupropion versus placebo, across all those 4 agents, there is no difference in neuropsychiatric adverse events. There is no statistically significant difference in neuropsychiatric adverse events across patch, bupropion, varenicline, and placebo. And that is the case when you look at the general population that was in this study, and it's also the case when you look at the population with established psychiatric disease, stable established psychiatric disease. And so what this trial should have done in terms of the choice of an agent that we use, the choice of medication that we use in general population, and even in those with stable psychiatric disease, it should have put to bed the idea that varenicline was dangerous or contraindicated. That was the headline certainly for me, and I think for treaters generally, that the varenicline causes suicidality thing was somewhat put to bed. Now we're talking about stable psychiatric disease. That's a sidebar that we don't get into today. But what I want to show you, having shown you how efficacious medications are in general population, is I want to show you the efficacy of medications in those with mood disorders. So if you look on the left of this slide, you see that the population is those who are 18 to 75, who meet DSM-4 criteria for a mood disorder and smoke more than 10 cigarettes a day. And you don't need to get into the numbers of that slide, but in summary, what we see is odds ratios for cessation of between 2 and 3 for varenicline, bupropion, and NRT. In other words, you approximately double or more the likelihood of quitting for those with mood disorders when they use these agents, varenicline, NRT, and bupropion. So these medications work in these populations is the point that we're trying to make from this slide. Eagle's headline was that these products are safe, but some of the sub-analysis show that they were actually effective in cessation as well. So how do we do it in the clinical setting? Well, as I said, we use these combinations, we titrate, we often end up being more aggressive than maybe the general population patient, if there is such a thing, walking into his family physician. We certainly try and honor patient preference. That's often the starting point. Patients will come along, and very few will come along and say that they are medication naive. Most will say that they've used this or they've used that, and it worked or didn't work, or their uncle used varenicline and it worked great and they'd like that. Most people come with a preference. And there's no reason why that shouldn't be the starting point for the choice of agent. As I've said, we titrate. We go to extended duration. So NRT is recommended for 12 weeks. Well, why would we treat for 12 weeks when someone's had a tobacco use disorder for 3 decades? We individualize the duration of therapy, and it's really much more effective to choose to reduce dose or to stop NRT when the patient is saying that they no longer crave, or that they're being quit for 3 months, or that they can walk past a tobacco user in the street and not have the desire to smoke. These are much better measures of reducing dose or stopping treatment than, hey, look, it's 4 weeks, or hey, look, you're at 12 weeks and end of treatment. Again, we're challenged by coverage, we're challenged by cost. But in an ideal world, we individualize treatment, and there's no reason why somebody shouldn't be on NRT for 6 months or 12 months or even actually longer. And then last of all, reduce to quit. So what do I mean by reduce to quit? So conventionally, we have suggested to our patients that they put their first patch on and they quit smoking that day and they never smoke again. And the reason that we've had this practice historically was this belief that there was something inherently dangerous about smoking whilst a patch was on. And we now know that that is not the case. And we've seen changes in labeling, and the FDA and others have said that there is nothing dangerous about concurrent smoking whilst wearing a patch. And so that opens the door for us to say, put the patch on and just see what happens. Put the patch on and see if you can reduce. And what that allows us to do is to make incremental goals. And for the tobacco user who has no confidence in their ability to quit, who smokes 20 cigarettes a day, to walk away with a patch on and find that they can reasonably easily, almost without trying, reduce to half that, because now they're getting nicotine from the patch, and inevitably their desire to smoke goes down. And then we can start to make these further targets. Well, do you think you can get down to 5 a day over the next month, and eventually roll into choosing a quit date at a point where the patient thinks that they can have success, rather than it being externally enforced by the treater. So reduce to quit is a very common approach that we use, and there's evidence that reduce to quit is no less effective in cessation than the hard quit date approach. This is just a reminder that though I've talked a lot about medications, behavioral counseling certainly should be a standard part of treatment. We know that counseling plus medications together gives us the best return on our treatment efforts, and whether it's one-to-one counseling in the clinical setting, or whether it's group, or whether it's the use of a quit line, we always recommend behavioral counseling when we're providing pharmacotherapy. Just a little reminder, stopping smoking can affect the blood levels of a number of medications that are commonly used in this population. I'll just highlight 2, caffeine and clozapine. So how does this work? Cigarette smoke contains a number of compounds, but the polyaromatic hydrocarbons induce the CYP1A2 liver enzyme system to metabolize some drugs more efficiently. So when you smoke cigarettes, you have this enzyme system in the liver metabolizing efficiently, and so you push down blood levels of clozapine. And the converse is the important bit. When your patient who has schizophrenia is admitted involuntarily to a psychiatric facility, or and therefore is not allowed to smoke, or is doing smoking cessation in the outpatient setting, as their cigarette consumption goes down, their blood levels of clozapine will go up, and they may become clozapine toxic. So we need to be aware of this. We need to be monitoring clinically, and maybe even doing blood levels, and be prepared to reduce doses if required. This is not a common phenomenon, the need to reduce doses, but it's one that we need to be aware of. Same applies to caffeine. So some of these patients are heavy caffeine consumers, drinking 10 cups of coffee a day. Maybe when they stop smoking, that 10 cups of coffee a day might actually start to feel like 20. And so what we mistake to be tobacco withdrawal might actually be caffeine toxicity due to the loss of efficiency of the CYP1A2 enzyme system when the patient quits smoking. So recommending that heavy caffeine consumers reduce their caffeine consumption when they try and quit smoking is important. You can find tables that list the drugs that are affected by this interaction, but be aware of it. So running out of time, already over, unfortunately. But just to summarize, the leading preventable cause of death worldwide is tobacco. This disproportionately affects the mental health and addiction population. Providers have historically not addressed this issue. We have efficacious counseling and pharmacotherapy options. We need better coverage. We need politicians, clinicians, researchers, a whole variety of individuals to push levers to make change in our systems if we're going to do a better job of this. These are the programs I've been involved with. On the left is the clinical program, the outpatient program that I've been talking about. We also run a group weekly at one of our big city hospitals. Haven't had time to talk about this. Maybe we can talk about it in the question session. Of course, vaping is increasingly a part of the story. On the left, you see a disposable vapor product there. Some of these are being banned in some parts of the world. And on the right is a current McLaren Formula One racing car with Velo branding. And we all thought we'd seen the back of this with Marlboro McLaren 30 years ago, 20 years ago, whenever this was banned, but we're seeing a return of this kind of practice. And this is big tobacco promoting their new nicotine products. So I'm going to stop there and allow what I think maybe 10 or 15 minutes for questions.
If you're interested in learning more, check out our website at bhwell.uky.edu.